selamlar. Bugün sizinle birlikte olmaktan mutluluk duyuyor.
A good day to all of you. I'm very happy to be with you today.
Turkish. I've always wanted to learn that language and never really had an opportunity. But thank you very much for the kind invitation to participate in this conference. I hope that the meeting is going well and that everyone will come away from it with some good ideas and the enthusiasm and the energy to move those ideas ahead with success. As you can all imagine, I would have much preferred to have been able to participate with you in person. I have very fond memories of being at this conference in earlier years and treasure my honorary membership in your association. Unfortunately, life sometimes gets in the way of the best plans, and so this video of my remarks will have to do for now. As some of you whom I count as friends know, I've had a long-standing and positive history with Turkey. In addition to attending previous conferences of this association, it has been my privilege to have participated in a number of projects in Turkey, ranging from teaching child and adolescent psychopharmacology to helping the University of Istanbul review its medical training program. I have also, in my new role, been working with the to Canada try and help strengthen bilateral economic and trade relationships. And I want to acknowledge the hard work that Professor Serdar Dursun has done to strengthen the academic ties between Turkey and Canada. We need more people with his enthusiasm and his commitment. So for me, today is a very special opportunity to be with all of you, albeit virtually. Hopefully, I will be able to attend an upcoming meeting in the near future in person and join in the wonderful hospitality that always characterizes this occasion. Since our topic is mental health literacy, it may be a good idea to start with being clear about what mental health is. As we all know, over the last decade or so, there has been quite a bit of time spent on mental health awareness building, and many anti-stigma programs have been created and deployed that address mental illness and sometimes some other important areas. However, although these awareness-building interventions may have had some positive impacts, they sadly have had some negative outcomes as well. One of these negative impacts has been to confuse the language that is being used. For example, people often use the term mental health when they actually are talking about a mental illness. I don't know how it is in Turkey, but in North America, people frequently talk about the stigma against mental health. There is no stigma against mental health. The stigma is against mental disorders or people who are living with mental. A lot of stigma against mental illness, the people that have a mental illness, and against the treatments that are being used to help people who have a mental disorder. Another good example of this confusion is the use of the word depression. In mental health awareness campaigns, there has been quite a big emphasis on depression. But what depression is was usually never mentioned. In these campaigns, depression was the mental illness called depression, not just feelings of negative or low mood. Yet because awareness campaigns were not informed by mental health literacy, they did not take time to explain to people what depression actually was. And because the word depression is also a popular synonym for sadness or unhappiness, people have now begun to complain about having a depression when they're feeling sad, upset, unhappy, demoralized, or experiencing any negative mood. And perhaps even more concerning is that many people now equate the normal, appropriate, and expected negative mood changes that occur in response to life's challenges as pathology. They consider the normal and appropriate emotional response to a negative life event to be a mental health problem that needs treatment rather than part of the expected condition of being a human being that requires the support of others and the seeking out of solutions to problems that we all encounter in our lives. A similar issue occurs with the use of the word anxiety. Once again, stigma programs have used the word anxiety when they're talking about anxiety disorders, which are inappropriate hyperarousal responses to normal environmental stimuli, such as generalized anxiety disorder or social anxiety disorder, or acute hyperarousal in the absence of an environmental stimulus, such as panic disorder. These cause functional impairment. However, these discussions have never been clear about what anxiety is. The inappropriate or overexpression of an arousal state to an environmental stimulus, or the experience of a hyperarousal state in the absence of an environmental stimulus. Instead, the word anxiety has been used to mean any state of emotional arousal. The word anxiety, with its meaning of an abnormal state of arousal, has replaced the many words that signal an appropriate state of arousal, such as concern, worry, perturbation, distress, and normal, situationally appropriate responses to life's challenges and opportunities have thus become pathologized. For example, in young people, the normal concerns, worries, and uncertainties when faced with writing an examination or going for a job interview, these are all normal and appropriate responses to the challenges and opportunities that these life events signal. These are called exam anxiety and job search anxiety. This not only creates the perception of pathology, but it also negates the purpose of this emotional response, that being to alert the young person that they have a challenge and an opportunity that they need to prepare themselves for. For example, if they're concerned about writing an exam, they may focus on studying more or getting additional help from their teacher. If they label their emotional state as anxiety, they're more likely to focus on alleviation of that emotional state, perhaps by seeking treatment, distraction, avoidance, self-soothing techniques, or even misuse of substances such as alcohol and soft drugs, rather than focusing on the work that they need to do to be successful at their exam. This is not helpful. Instead of recognizing that the stress response, the normal, accepted, and necessary brain and body response to every and any challenge or opportunity that exists in our lives, is there to alert a person to something that they need to be aware of, respond to. People now label that necessary driver of adaptation as pathology. And instead of using that state of arousal to identify and effectively deal with the challenge or opportunity that is facing them, people avoid the situation or focus instead on decreasing the arousal state instead of engaging in the work necessary to successfully deal with the challenges or opportunities that they are facing. This illustrates a fundamental misunderstanding of the stress response, often just shortened to the word stress. Misunderstanding that well-meaning awareness programs have promoted, and that profit-seeking vendors of so-called anti-stress programs or products have exploited. This has also muddied the difference between self-care and self-indulgence, and promoted the explosion of the wellness industry, trillion behemoth promises you a product or service that for a price will make you feel better briefly, but it knows that soon you will want another boost. And of course, will have another product ready for you to spend your money on. And then the cycle will repeat and repeat and repeat. The perfect neoliberal capitalist model of unending profit derived from selling an unnecessary product to meet a never-ending want. The wellness industry flourishes. Scientific health and mental health literacy is poor. So, what is stress anyway? It is the stress response, the emotional, cognitive, and behavioral reaction to a stimulus from our environment that alerts us that we need to take action to address a life challenge or opportunity. Our experience of stress is the first step on the pathway to adaptation. Once we experience and properly identify the stress response, the next step is to problem solve. What is the challenge? What is the opportunity? How will I successfully address this? Who do I need to talk to help me? What do I need to do? Then we plan and we apply what we have planned. If we're successful, the stress response signal goes away and we have learned something, perhaps developed a skill. The next time we are facing a similar situation, we apply what we've learned. This process occurs over and over and over every single day of our lives. It's called adaptation. And repeated successful adaptation creates in all of us the competencies that we call resilience. No stress means no adaptation, and this means no resilience. And it is important to remember that this stress response is the driver of everything that has improved the human condition since the beginning of time. Simply put, if we are not feeling distress, we have no reason to do anything. That includes not bothering about racism, not caring if there is equality or if we have clean drinking water or if our elected officials are stealing money from our taxes. Why should we bother about climate change if we're living in comfort and are not distressed? Sometimes we need a bit of additional help to manage the intensity of the stress response, such as stress reduction techniques, and that's fine and that's good. But if we immediately resort to these techniques, we experience stress. Instead of focusing on what we need to do to successfully address the challenge or opportunity that we face, we may end up not developing the skills needed to adapt. Over time, we become less and less resilient. Similarly, if we immediately turn to self-soothing when we feel distress, we become distress intolerant. And over time, this also becomes a barrier to building resilience. This reality may help explain some of the findings in mental health surveys on university campuses, where students self-report extremely high levels of stress in a situation that 20 years ago would never have engendered that same self-evaluation. Some thinkers suggest that current post-secondary students are not facing substantially more challenging environments than they were 20 years ago. Indeed, some argue that their environments may be more pleasant than before, but the students themselves are much more distress intolerant, and when they arrive on campus, and thus are ill-prepared to take on the normal challenges and opportunities that being at a university entails. Indeed, it was this realization that led my team and I to create the life skills resource called Transitions, a mental health literacy intervention that can help promote success at this point in a young person's life course. You find it online at mentalhealthliteracy.org/transitions. Dr. Way, the University of Alberta, who is with you at this meeting, has done groundbreaking work on addressing mental health literacy on campus and in schools, and I understand that she will be speaking about her work at this conference. It is my hope that some of her work can be replicated in Turkey, a fitting new collaboration between Canada and Turkey. So all this brings us back to the same issue that we started with. What is mental health? Well, as we have seen, mental health is not about feeling good all the time. It is about having normal, situationally appropriate, emotional, cognitive, and behavioral responses to the challenges that life gives us. It's about embracing and engaging with the pains and sorrows, as well as the joys and happiness that is part of the human condition. It is also about not expecting to feel good all the time. It's about learning how to adapt and how to become resilient. Sometimes that learning can be painful, but the presence of that pain doesn't mean you have poor mental health. Contrary, it's a signal that you have good mental health. It means you are engaging with your life, not avoiding it. That does not mean that every stressful situation that causes pain is a good step. It's good mental health. Some stressful situations are clearly not. Indeed, the opposite. They can lead to maladaptive or even harmful effects. But we have become sloppy in our thinking about these things, and we have taken the reality that some stressful situations can have negative impacts and generalized that all stressful situations have negative impact. This also does not mean that good mental health is totally the responsibility of the individual. There are structural and systemic issues at play that make it much more difficult for some than for others. Example, poverty, racism, sexism, homophobia, physical or psychological abuse, and so forth. These create an uneven playing field. Good mental health requires us to effectively deal with these significant and unhealthy social determinants. Also contrary to popular belief, mental health is not on a spectrum, with good mental health at one end and mental illness at the other. People do not progress inevitably along a path from mental health to mental health problems to mental illness. Most people with a mental illness actually have good mental health concurrently with their illness, just like people who have a chronic illness, such as diabetes or HIV/AIDS, can have the illness and be healthy at the same time. We need some good mental health literacy to put things back on track. For example, the information found on the website mentalhealthliteracy.org or the teacher training and school mental health literacy interventions found on the University of British Columbia site teachmentalhealth.org are places to look. And I highly recommend the Harvard University Center for the Developing Child's resources that help us understand the difference between positive stress, tolerable stress, and toxic stress. You can find it on the developingchild.harvard.edu website. So we have actually been doing some mental health literacy since the beginning of my talk with you. Let's put this into context. Mental health literacy is part of health literacy, which itself is based on scientific literacy. Taking together, these three building blocks are the foundation on which the house of good health at both population and individual levels, and good health care, including self-care, is built. Good health literacy is considered by the World Health Organization to be as important as many of the other social determinants of health. In its 2013 monograph on health literacy, the WHO states, quote, health literacy, is a stronger predictor of an individual's health status than income, employment status, education, and racial or ethnic group, end quote. Page 7 of the monograph. Mental health literacy is comprised of four distinct but overlapping components. These are 1, understanding how to obtain and maintain good mental health. 2, understanding mental disorders and their treatments. 3, decreasing stigma associated with mental disorders and their treatments. And 4, enhancing help-seeking efficacy, knowing when and when not to seek care, where to seek care, having the competencies to enhance care-seeking experiences, having self-care understanding, and self-care competence. Well, these are all necessary components of mental health literacy. How these are achieved can vary. But before continuing to address that, it is necessary to comment on what mental health literacy is not. Mental health literacy is not having a flashy website with information about mental health and mental illness. Remember, information does not equal knowledge, and knowledge does not equal understanding. Mental health literacy is not a collection of sound bites from celebrities. Mental health literacy is not a march along the street or a designated day of the week or month or year. Mental health literacy is not a song, movie, or a series of social media engagements. And mental health literacy is not necessarily a classroom resource that has not met robust research to see if it's effective, to determine whether it can be provided by teachers, and have those teachers been actually trained in using effective interventions. Mental health literacy also needs to be effective, and all interventions that call themselves mental health literacy interventions must be able to demonstrate effectiveness in each of the above 4 domains using robust quantitative research, preferably longitudinally applied cluster or random sampling techniques, and comprehensive statistical analyses. Measurements must be valid, specific to each of the components and to the construct in general. It is important to stress that self-reports of satisfaction with an intervention are not a substitute for rigorous analysis of the effectiveness of that intervention. Unfortunately, when we apply these necessary criteria to both identify and evaluate mental health literacy impacts, the scientific literature does not support many of the so-called mental health literacy interventions at use today. This forces us to search for those responses that have made those standards and not rely on salespeople or enthusiasts who use the title mental health literacy to promote or sell their products. Mental health literacy should not be part of the wellness industry. In order to be successful, a number of important considerations about the application of mental health literacy interventions that have already demonstrated effectiveness in robust research are needed. Remember that these are in addition to the interventions already having demonstrated robust evidence of effectiveness. But first, we have to make sure that the intervention is effective in those domains that we have discussed, using proper study design, proper statistical analysis, and proper analysis and discussion of that analysis, interpretation of the analysis. But in addition to that, a number of other things are necessary. First, mental health literacy interventions need to be developmentally appropriate. The focus and delivery of mental health literacy interventions must meet the needs of the target audience. Interventions are not a one-size-fits-all. How mental health literacies are provided to primary schoolers is very different. How those interventions are provided to secondary schoolers and to post-secondary schoolers. And for each group, this necessary research must be done. Fortunately, much of this work that has been done by the Canadian group that Dr. Wei is part of, and in other countries, can use this material to adapt that materials for their own populations and then engage in the robust research to determine whether those adaptations are effective or not, developmentally appropriate adaptations. The second is mental health literacy interventions must be embedded into existing institutions. This means that for young people, mental health literacy interventions must become part of the school curriculum and provided at different points during each student's educational journey. Pre-teacher training programs should also include mental health literacy training. Teacher professional developmental courses should be regularly available. If the teachers themselves are not mentally health literate, how can the teacher teach mental health literacy to the student? One wouldn't expect a teacher who knows nothing about mathematics to try to teach mathematics. Why would we expect a teacher who is not mentally health literate to try to teach about mental health to students? And there are good training programs available online and at no cost, certified by 3 of Canada's best teaching faculties to do that. If in Turkey you want to follow up on this kind of work, speak with Dr. Wei, modify the materials for your teachers and use them. The third thing is that mental health literacy interventions must be valued and funded by the institutions who have responsibility for education and health. This means that bureaucrats in both of these areas of responsibility and politicians must champion and ensure that mental health literacy interventions are robust and ongoing, that funding is secure and perpetual. It takes an effort to develop these linkages with various governments, but this pays off. In my current role as a Canadian senator, I've become aware of how important it is to have parliamentarians and bureaucrats understand these concepts of mental health literacy. And if any of you would like me to chat with some of your bureaucrats and politicians, I'd be happy to do so. Fourth, while there is much yet to study, learn, and develop in the field of mental health literacy, there already exists a very well-researched and demonstrated effective intervention, particularly for schools, directed for both students and for teachers, designed for grade 6 to post-secondary. Considering how well-researched and how effective this intervention is, classroom-based curriculum, Turkey might want to consider adapting and evaluating what has already been demonstrated to work, and then using an implementation science-based framework to scale up. It does work. These Canadian materials have been translated into many, many languages and evaluated in many, many different countries, and the results have been really positive in every one of these locations. Turkey could be another location. Fifth, an obvious location for advancing mental health literacy that is, however, not very much utilized, is through collaboration with healthcare providers, especially primary care and mental health care clinicians, psychiatrists, neurologists, neuropsychologists, pharmacists, linking with existing clinical services to promote and distribute best available evidence-based mental health literacy materials can be a cost-effective method for reaching large numbers of people. So these materials can be available in all health providers' offices. They can be used to help educate a healthcare provider could be exposed to evidence-based mental health literacy interventions, and that would improve the mental health literacy of the entire population and also of the provider. So there we have it. And we're coming close to the time that I was allocated to chat with you. But before I close, I want to bring to your attention a key component of mental health literacy that the Turkish Association of Psychopharmacology could play an important role in addressing in Turkey. Perhaps some members of this audience who are here today could collaborate with Dr. Wei and Dr. Durson to advance this topic. That is, putting effort into an important and often neglected focus of mental health literacy. That focus is on treatments for mental disorders in general and for medication treatments in particular. The misinformation and actually the disinformation that is now present about the many well-established and effective psychopharmacologic treatments is legion, and that disinformation is growing. Almost not a week goes by that I don't see some media, social media trumpeting mistruths or total untruths about medications. These medications help people who have a mental disorder live better lives. This kind of disinformation creates stigma against effective treatments that pushes people who need medications to avoid taking them. This kind of disinformation causes huge problems in the lives of people who need these treatments to be well, and great anguish in their family members who have seen how helpful these treatments can be. This information thrives when people have poor mental health literacy. Disinformation is a huge problem in many things in our lives now, including disinformation about the treatments that help people who have mental illnesses get well, stay well. This association can take up this important challenge and work to create and deliver effective mental health literacy interventions that provide honest and truthful information and break the stigma associated with the pharmacologic treatments for mental disorders. I can think of a strong collaboration between the Turkish Association of Psychopharmacology and Dr. Way, Dr. Durson from the University of Alberta in Canada. Additionally, Dr. Glenn Baker, an internationally recognized neuroscientist, also from the University of Alberta, would make an additional outstanding partner. Together with Turkish leadership, such innovators could go about building an effective and robust mental health literacy focus on the medication treatments for mental disorders. Evaluating those interventions, seeing whether they make a difference in Turkey, and if they do, applying them, adapting them, and using them in Canada as well, and doing that kind of really, really important research that will help people who have mental illnesses live better lives, but also will effectively address the disinformation about the treatments for mental disorders. That happens, if you do is create this kind of work together, you can count on me to help in any way that I can. Closing, I want to just thank you all for your interest in mental health literacy. And I would once again like to thank you and thank the organizing committee for inviting me to speak to you and be with you, albeit briefly, and by video today. I very much look forward to a time when I can visit with you in person, join with you together at this very, very important and outstanding meeting. Once again, teşekkür ederim. EEC.